The Western New South Wales Primary Health Network acknowledges that we work on the traditional lands of many Aboriginal nations. I would like to pay respect to elders, past, present and emerging, and acknowledge the traditional custodians who care for this land on which we work and live. I acknowledge and respect their continuing culture and the contribution they make to the life of the communities in our region. This webinar is being recorded this evening and will be available to view for a limited time after the live session, and I'll be sure to cut that 15 minutes off the beginning so you don't have to go through that again. We will send a link through to everyone who attends, and if you have any colleagues that weren't able to attend, we can certainly forward them the link as well. At the completion of the webinar, we'd really appreciate if you could take a brief moment to complete the evaluation survey. The link was sent around in the reminder email. You would have received about an hour before this webinar, and we will also have a QR code in the final slide that you can get out your smartphone, scan with your camera, and it should take you to the evaluation. We really value your feedback, and we certainly use it to guide each year's immunisation update. So if you can please take a moment to do that, we'd really appreciate it. For anyone who hasn't been to one of our webinars before, the way to ask questions and interact with your presenters is through your toolbar. If you can't see your toolbar, look to the right-hand corner of your screen and there should be a small orange triangle. If you click on that, it should pop out your toolbar and it should look like this image below. Just a bit of housekeeping. Every participant is in listen-only mode, and this is just to optimise the sound quality. If you do have questions, please pop them in the question pane. If you can't see the square to type your questions in, just pop on the little triangle next to questions, and you should be able to pop your questions in there. Put them in throughout the presentations, and at the end of each presenter, we'll have a bit of a Q&A session. So before we pass over to our presenters, we'd just like to give you a bit of an update on the Western New South Wales PHN coverage rates. And this is a table of the rates with the most recent data being March 2020. And what this table tells us at a quick glance is what an amazing job all of the immunisers and health practitioners are doing across our region. You can see that in many of the categories, our rates that were already high have continued to rise, with our PHN being the highest in Australia for one group and the second highest by the tiniest of margins for two other groups in the March 2020 quarter. We just want to take this opportunity to congratulate everyone for all their continuing hard work and commitment to protecting the health of the kids in our region. So, moving right along, the first topic on our agenda tonight is working together to improve Aboriginal and Torres Strait Islander immunisation coverage, which is being presented by Katrina Clark. Katrina is the National Indigenous Immunisation Coordinator at the National Centre for Immunisation Research and Surveillance, that we all know as NCIRS, and she's based in Sydney. Katrina is a proud Barkindji woman from far western New South Wales. She has a graduate diploma of Indigenous Health Promotion, a diploma of Population Health, and a Certificate 4 in Indigenous Research Capacity Building. And on top of that, she's currently enrolled in a Master of Public Health at the University of Sydney and has a massive assignment due tomorrow. So we really appreciate her being with us tonight. Katrina's current role with NCIRS involves working with the National Aboriginal and Torres Strait Islander Immunisation Network to promote communication between the National Immunisation Committee and stakeholders involved in providing immunisation services to Aboriginal and Torres Strait Islander people. Katrina is committed to ensuring equity of access to immunisation for Aboriginal and Torres Strait Islander people. And I will now hand over to Katrina to start her presentation. Thank you so much, Katrina.
Okay, can everyone hear me? Is that okay? Can you see my slides?
Yep. We can hear you and see you. Thanks so much.
Lovely. Okay. So thanks for that lovely introduction. So I would also like to acknowledge country as well. So I acknowledge and pay my respects to our elders, our ancestors past and present, for their strength and resilience and their wisdom. And as a proud Aboriginal woman, I was also a proud Barkindji woman as well from far western New South Wales. So a big cheerio and a hello to all the mob out there in Wilcannia, Ivanhoe and Broken Hill. So that's where I grew up. I would also like to extend that acknowledgement to our non-Indigenous colleagues online this evening as well, that walk with us to continue to support the best possible outcomes that will not only affect today, but in ways which all health services are provided to Aboriginal and Torres Strait Islander communities for our future generations. So tonight I will be providing a brief overview of existing opportunities for improvement and highlighting the inequalities in disease burdens for Aboriginal and Torres Strait Islander communities, as well as addressing the rationale, as well as discussing the rationale behind the current immunisation schedule for our at-risk groups and the the changes that came into effect on July 1. The reason why I and many more Aboriginal healthcare professionals advocate for cultural capability in the healthcare system is because we hear so many times, I treat everybody the same. And in fact, when we talk about equity and equality, we actually can't give everybody the same thing because we have started in a different place. And in the case of Aboriginal and Torres Strait Islander Australians, if we look at policies past and present and the laws that prevented, my grandfather, my grandmother, my mother, me, we Aboriginal and Torres Strait Islander people from progressing in society, the ongoing effects, of forced separation of families, entrenched discrimination, followed by our inequalities of our basic rights. So we're already behind the 8th ball. So it's kind of like the image now that you already see on the screen, the image of the fence. If we continue to give everybody the same box to see over the fence, nothing changes. We have to give people what they actually need to be able to achieve equity in Australia. Oh no, it's not working. Oh, there we go, it's working. So simply this means Aboriginal and Torres Strait Islander people, we require extra vaccines. So this may require you as a healthcare professional that provides vaccines to Aboriginal and Torres Strait Islander people. It means that we have to work differently to ensure this occurs. So doing the same thing, we're actually reproducing inequity. It's not the same. We need fairness, and trying to solve the inequalities assumes that we all have the same opportunities. The same opportunities and experience, when the reality is that we Aboriginal and Torres Strait Islander people, we continue to experience racism, and this makes this untrue. So only when we begin to address the inequalities can we really can the playing field be really truly level. So the next couple of slides, I'm going to talk now about the burden of diseases and just show you the inequity within these burdens. So a lot of the stuff that a lot of the graphs that I'm going to be talking about tonight, they come from NCIRS 2 reports that were published late in 2019. Historically, immunisation has been and remains a safe and timely, effective and affordable way to improve Aboriginal and Torres Strait Islander health, delivering positive outcomes for Aboriginal people of all ages. However, Aboriginal and Torres Strait Islander children still experience high rates of vaccine-preventable diseases compared to non-Indigenous children. So during the presentation, I really hope to answer just a few questions to why the NIP schedule is different for Aboriginal and Torres Strait Islander people by giving examples of vaccine preventable disease disparities, as well as highlighting the NIP gaps. Here we can see the rates of invasive pneumococcal disease notification by age and Indigenous status in Australia between 2006 to 2015. The burden of IPD disease remains high in Aboriginal and Torres Strait Islander people despite long-standing vaccination programs. However, as you can see by the solid blue line, it's 3 times higher in less than our 5-year-olds. And then, as you can see by the solid red line, it's 10 times higher in our 5 to 49-year-olds, and then 6 times higher in our over 50-year-olds. That's compared to non-Indigenous Australians. And I'm sorry, Lisa, I think this is where I was meant to mention the poll as well that was coming out. So apologies for that. The recommendations for pneumococcal vaccines, they have changed for Aboriginal and Torres Strait Islander people as of July 1. This is a more recent report as well I've found of pneumococcal disease incidence in Indigenous Australians. As you can see, you know, the burden is 7 times fold higher than non-Indigenous Australians. Given that we Aboriginal and Torres Strait Islander people make up less than 3% of the total population of Australia, but you know, cases in 2018, Aboriginal and Torres Strait Islander people, you know, made up 11% were, you know, cases were Indigenous Australians. And now we move on to meningococcal disease. So as we're all aware, meningococcal disease, it's quite rare, but it's very serious. And this graph shows the rates of meningococcal disease notification by rates and status in Australia between 2006 to 2015. As you can see that by the red line, meninge C notifications has almost disappeared at the commencement of the meningococcal C program in 2003. However, meningococcal B disease rates remain several times higher amongst Aboriginal and Torres Strait Islander people than non-Indigenous people. You know, it's 4 times higher in under 5s and 6. It's 4 times higher in our under 5s and 6 times higher in our 5 to 14-year-olds. You know, subsequently to the period of this graph, meningococcal W and Y strain has also emerged as a cause of disease, which is much higher in Aboriginal and Torres Strait Islander people. So, and meningococcal ACWY was added to the NIP in 2018 for all children at 12 months of age, and also for adolescents at 15 to 19 years of age. However, given the additional meninge ACWY to Aboriginal and Torres Strait Islander children, should we also, given these rates, you know, the 6 times higher, should we also be giving it to these age groups? So that's the 5 to 14-year-olds. So that's like our NIP gap at the moment. This is the recent data of meningococcal B notification by Aboriginal and Torres Strait Islander people compared to non-Indigenous Australians. So this was recently published in the MJA paper, I think it was about 2 months ago. And as you can see, the disease is more common in young children, less than 12 months of age. It's 2 times higher in our 12 to 23 months compared to our non-Indigenous children. And it's 11 times higher in our 2 to 4-year-old children compared to non-Indigenous children. So that's our blue line, and then it's also 7 times higher in our 10 to 14-year-olds compared to non-Indigenous children. So this is one of the good news stories, I suppose. Like this vaccine now is on the NIP from July 1 for all Aboriginal children up to 2 years of age and other risk groups. So this data, and I'm hoping this data really drives that conversation as well. When you have those conversations with non-Indigenous families about why Aboriginal children are receiving this vaccine, it's because of these disease disparities in the graphs, you know, in the rates that you can actually now see on the screen. Here's a good real success story at a national level, and it's a great example of equity, of giving people what they actually need to receive the best possible health outcomes. You know, prior to the introduction of Hepatitis A program in 2005, the rate of Hepatitis A disease was 5 times higher in our Aboriginal children, Aboriginal and Torres Strait Islander children, compared to other Australians. Following the introduction of the program in 2005, in children aged 12 to 24 months in Western Australia, South Australia, and Northern Territory and Queensland. So these were the 4 jurisdictions with the highest rates of disease. We can see that notifications for these jurisdictions have really sharply declined and have remained lower as well in all states and territory now for Aboriginal and Torres Strait Islander children. But from July 1, those states and territories that I've mentioned, so this does not include New South Wales. So this is just at a national level. So I was just showing you our, you know, the example of great equity and health week, just giving people what they need, and then we can all achieve health equality for our Aboriginal and Torres Strait Islander children and people. So in summary, tonight I hope that I've shown you that despite the successes, there are still disparities in all numbers of vaccine preventable disease. You know, vaccine coverage it's pretty good, and in fact, the latest immunisation coverage rates are for Aboriginal and Torres Strait Islander children to be at record level across all ages. So, you know, we really do need to keep it that way. However, the delay in immunisation and the vaccine preventable disease, it still remains a significant health issue in Aboriginal children. And this is why we need to really focus on making sure that all Aboriginal and Torres Strait Islander children, they receive their scheduled routine vaccinations on time. So, you know, the 2 changes to the NIP, it will improve 2 diseases with the high burden for Aboriginal and Torres Strait Islander children, people. So that's pneumococcal disease and meningitis. So as I said previously, I really hope that showing the reason and showing those graphs around to why these changes were important for Aboriginal and Torres Strait Islander children. So this is why we really do need to make sure that our children receive, you know, those vaccines, so we all can have that level playing field to make sure that our children receive those, you know, important vaccines on time and at a timely manner. So what can you do as a service provider? Indigenous issues, it can be daunting. It's easy to slip into a state of helplessness and convince yourself that nothing you will do will help, or you're scared to try in case you end up doing something wrong. It should be more about your responsibility as a human being and as an Australian to understand the situations in which Indigenous people find themselves in, and how you can be empowering and a positive force in fighting, you know, for the rights for Aboriginal and Torres Strait Islander peoples of this country. So it's important to identify your Aboriginal and Torres Strait Islander families. It's you know, it's important to know whether your family identifies as being Aboriginal and Torres Strait Islander, as this ensures the care and services provided are both clinical and culturally responsible. So deciding if a person is Aboriginal or Torres Strait Islander based on looks, features, appearances, it's not acceptable. The only sure way to find out if your clients identify is to ask the routine question, you know, do you or your children identify as Aboriginal or Torres Strait Islander? So as I said earlier, asking this question, it ensures that the care and the services that we provide as healthcare workers are both clinical and culturally responsive. You know, the correct identification also helps service providers to refer families onto other services, such as recommending the routine screening and health checks at a younger age, referring on and linkages to external services that are designed for Aboriginal and Torres Strait Islander people located in your communities. And also just to be aware of the NIP schedules and the variations between state and territories, because our families, we are very transient as well. You know, we don't normally stay in one place. We're always visiting family or, you know, extended family. So just being aware of that the NIP schedules for different states and territories. So in summary tonight, I hope that I've shown you, despite the successes, and there are still disparities in the number of vaccine preventable disease. As I said, vaccine coverage is pretty good, but we just need to make sure that we continue to offer immunisation at all visits. You know, a lot of the healthcare, we respond to, you know, Aboriginal healthcare. We don't respond to the health promotion of you know, positive reinforcement of Aboriginal and Torres Strait Islander people. So we just need to make sure that we continue to offer those routine immunisations at all visits to your services. So thank you and happy immunising, everybody.
Thank you so much, Katrina. That was wonderful. If anyone's got any questions, if you could just pop them in now, Katrina can answer those before we hand over to Nick. Have we got any questions, Michelle?
We've got a lovely compliment. We've got a response that is the best picture, Katrina, that this lady has seen to explain equity and equality, difference between equality and equity. So very good.
It is. It's a wonderful image, that one.
Thank you.
Wonderful.
And thanks for the comment, Jennifer.
Okay, well, given we're running, have we got another? Given we're running a little bit behind because of our technical issues, I might pass to Nick Wood now. Nick will be presenting an update on Influenza 2020, including the impact of COVID-19, and a presentation on the updates on the NIP from the 1st of July for Meningococcal and Pneumococcal. Nick is a staff specialist general paediatrician and associate professor and subdean, higher degree research in the discipline of child and adolescent health, Faculty of Medicine at the University of Sydney. Nick leads the New South Wales Immunisation Specialist Service and coordinates the Immunisation Adverse Events Clinic at the Children's Hospital at Westmead. Nick is very interested in maternal and neonatal immunisation, as well as research into vaccine safety and the genetics of adverse events. And I will now pass on to Nick. Thanks so much, Nick.
Thank you, everyone, and hello. I'll just make sure I get the screen up. I hope you can hear me and see that. Is that working?
We sure can. That's perfect.
Okay, excellent. So, and thanks to Katrina, and I'd also like to acknowledge the traditional owners of the land on which we talk across, both sides of the Great Divide, dividing range, It is a shame that we can't get out there over the hill, because we do like coming out to the western part of New South Wales. So I'm sorry about that. But it is an important time to give an update, because it's basically nearly 1 month into the change in the National Immunisation Program. So what I'll try and cover for you in the next little while is the strange beast that we are in at the moment with COVID. I'll tell you a little bit about what's happening with flu, and then, as mentioned, the changes to the NIP, and what sort of resources there are to support you guys out there in the front line. And I think it is particularly, you know, a huge success and credit to you guys to have such high coverage that was shown earlier tonight, which is fantastic. And unfortunately, the changes to the program just make that a little bit harder to keep the coverage up. It is a unique 1 in 100 pandemic that we are in at the moment. These sort of is at a glance showing the figures, and I think this sort of what illustrates is this sort of first group here, and then the second group here, which, as everyone knows, is coming predominantly from Victoria, although there are now hotspots in Sydney as well. And so there's a very good website. There's a government website. There's another good website, which is just called COVID-19 Data, which is very accurate as well. So this is what we showed a little bit earlier. This is the numbers from the first wave and now the second wave. And that has implications for routine vaccine programs, not only in Australia but internationally. And unfortunately, we're seeing outbreaks of traditional vaccine preventable diseases in some countries, like measles in the Philippines, coming back. I just wanted to quickly update you with where we're at with the vaccines, and how we will probably be coming back to you, I suspect, in the next couple of years, talking to you about the COVID vaccines, not only their developmental stages, but when they start to get into routine use in the community. So as of just a few days ago, there are more than 166 candidate vaccines that are in the pipeline. 25 of those have gone into human clinical trials. And this is sort of a bit of a breakdown of those. As you can see, there's different platforms that are being used, inactivated protein, viral vectors, DNA, RNA, and they're in different phases. So normally the pipeline from a phase 1 to a phase 3-4 trial is at a minimum of usually about 5 years. But these things are being run back to back. And so, as you can see here, some candidates are already in the phase 3 trial. The phase 3 trials are the trials where we try to do it in tens of thousands of subjects. And not only are they looking at the sort of safety and immune responses, they're trying to see if these vaccines are effective. Whereas the early phase 1 and phase 2 trials are predominantly looking at the safety, and they're in much smaller numbers. So hopefully the next stage after the phase 3 is if the company believes there's enough safety, immunity data, and ideally some effectiveness data, that it can be then go to licensure within the people like the FDA or the TGA. Okay. In Australia, we're playing our part. So this is the 4 candidate vaccines that have been gone into clinical trials in the phase 1, phase 2. There's the Novavax study, which is done in Melbourne and Brisbane. There's a new one which has just started recently from South Australia. It's a homemade vaccine from South Australia. There's one in Perth, and there's also the one which is another homegrown one, which is the University of Queensland, which is an interesting clamp technology. So they're the sort of the trial activity that's happening in Australia, and probably if they're successful, that will roll on to phase 2 trials as well. Okay, so that's a little bit about the COVID vaccines and where they're at. In terms of the flu season for 2020, well, to be honest with you, it's a bit of a non-flu season. This is the media that has been sort of showing around. The fact that we've been distancing, the fact that people are probably washing their hands more and more recently wearing masks has certainly had an impact on flu. And this is the classic graph which is being shown, and the red is the flu for this year, essentially no flu at all. Okay, now that's despite testing. Now people are testing for COVID obviously, but they're also testing for other viruses, particularly when you get to the hospital environment. And that compares, you know, quite remarkably to the previous years of 2019 and 2018. So really no flu at all in Australia at the moment. In terms of the safety of the vaccine, this is data that's coming from AusVax Safety. You can see a web link down there. We've shown this in previous years, and it's a good place to go to if you want to see weekly updates on the safety of these vaccines. Just to remind you, this is a system that when people get the flu vaccine, they get a text message in the 72 to 96 hours post that vaccine to ask for any adverse event. And it's being across the country, and these are in the figure of the map of Australia, you can see the number of participants that take part in this signal detection system. Nearly 280,000 participants across Australia, and only 5%, which is 1 in 20, are reporting any adverse event. And the bulk of those are things like injection site reactions, like a red sore arm, with very few having fever. And importantly, less than 1% have reported that they had to go to the doctor or emergency department. So this is encouraging data, and on the website you'll see a breakdown by the brand of flu vaccine being given as well. So that's really, really useful. So even though it's not much flu at all circulating, if someone does want to get the flu vaccine, it's never too late. So I would continue to offer that vaccine. We don't really recommend revaccination of the same strain or the same vaccine each year. And I know there will be a question about this. Should you know, if you're a chronic medical illness person, should you get, and you had a vaccine in March, should you get another flu vaccine in October, November? The general advice to that is it's not recommended, but it can be done, but it's not routinely recommended. If you're a pregnant woman or a traveller and you're particularly going, say, for example, which you won't be doing, but if you're going to be going to the Northern Hemisphere for their flu season, you might think about getting a dose before you go. And a pregnant woman can get the vaccine at any time of the year as well. So if they're pregnant right now, although there's no flu, I would still be giving them the flu vaccine. Those that are recommended to get 2 doses are the kids who are aged 6 months to less than 9 years, who are getting their first dose or their first exposure to the flu vaccine. Okay, so that's the routine where they are recommended to get 2 doses. But those that have got chronic medical illness, probably not, you know, routinely recommended that they get a second flu vaccine later that year. I know some people are doing it, but if the person said to you, should I get a second dose, you can say, well, it's not routinely recommended, and there really isn't much flu at all at the moment. So it's up to you to think about whether you want to do it or not. Okay. Just wanted to highlight this particular issue, which we found out has been reported a little bit today when we were talking to New South Wales Ministry of Health, to their adverse events section. There have been a few reports of this problem known as SIRVA, which is shoulder injury related to vaccine administration. And why that comes about is that the vaccine has been given too high in the deltoid, okay, or even too low. But the one they worry about is the too high. And the reason is shown in this little graphic here. I don't know if my arrow works when you can see it, but the deltoid muscle is here, and it gets quite thin the closer you get to the acromion, which is that sort of plate on the top of your shoulder. This here is a bursa, and it's a fluid-filled sac. And so if it's given too high, the needle can go in here and inject the antigen, the vaccine antigen, into this bursa, and the bursa doesn't like to have foreign material in it, and so you can end up with a bursitis. The problem with the bursitis is that you end up with a very significant pain in your shoulder, and it can last for weeks and can require them to have regular visits to rheumatologists. They might need steroid injections to dampen down the inflammation. So it's can be a big deal for some people. So obviously you know all this, but just to remind you that the correct landmarks, and really don't give it too high, because this is a bit of a public messaging, because there have been some reports to New South Wales Health of this server problem. Lots of information out there, resources for flu, available on the New South Wales Health website. There's the link down there. Okay. All right, so moving quite speedily through the changes that have been in place now for about 28 days. And they're all listed on the health.gov.au immunisation section. There's lots of information there. These are really just things that you can take away and read at your own leisure. The New South Wales immunisation schedule has also been updated, and this is the new one here, again available on the health.nsw.gov website. Here are the key changes, and we'll go through each of these in detail. Katrina's talked to you a little about the MenV and the pneumococcal, the rationale behind them, particularly for the Aboriginal and Torres Strait Islander. But we'll go through, and these are the vaccines that have had changes to them. Okay. And really, what the aim of it was to improve protection and to make it a simpler system, therefore making the vaccine more available for those that are at increased risk of pneumococcus, meningococcus and Hib. And the reason you might be at increased risk for those particular 3 bacteria is because of your underlying age, i.e. the older you get, because you've got an underlying medical condition, or as Katrina has shown you earlier, because of you're an Aboriginal or Torres Strait Islander person. Okay. This is a catch-all table that is designed to try and show you some of the key changes. I won't spend much time on this, but this is something that you might find useful to have a look yourself, but really to go through in detail each of the changes to each of the vaccines. So the main reason that they changed the pneumococcal vaccines was because, and I know I found it tricky to understand, and I'm sure people also trying to give vaccines did, the category A and the category B at-risk conditions was very, very tricky and complicated, and probably overly complicated. And so that's been tried to be simplified. Meningococcal B is now funded for all Aboriginal children as part of the routine schedule, and for those that have these underlying problems with your spleen. Now you need a good spleen, a functioning spleen, to particularly deal with meningococcal bacteria. So if you haven't got a spleen, or your spleen's not working, that is, it's hyposplenic, then you're at risk of getting nasty meningococcal disease. Also, if you've got this complement problem, which is quite a rare immune deficiency, or if you're on a drug called eculizumab. Meningococcal A CWY is the same sort of story and the same rationale, again, because you need a spleen to deal with the meningococcal bug. Okay, same for the Hib. There's a bit of a pattern, a bit of a theme here. These bacteria are what we call encapsulated bacteria. They have a polysaccharide capsule on them. And any bacteria that has a polysaccharide capsule, like pneumo, meninge, and Hib, you need a good spleen. Okay, so if you can walk away thinking, hey, no spleen, that means those 3 bacteria, pneumococcus, meningococcus, and Hib, increased risk, therefore I better give extra vaccines. There's lots of information on the ATAGI pages, and they break it down by each of the changes. Okay, so I might just stop there and see if we can get this poll thing to work. I'll just, here we go.
Yep, so the poll should be up for everybody. If you can just take a moment to choose your answer. You can see lots of responses coming in. I'll just give you a few more seconds. The answers are all anonymous too, so please don't be worried to join in. We're getting there. Okay. We've nearly got everyone voting there. So I might close that off now and share the results with everybody.
There's some people that are
So it looks like, Nick, 84% of people thought it was all of the above, with a few mixed answers from the answers above there. And I'll now hide that poll for you. And we're back to you, Nick.
Okay, we're back on. So now we'll just go some of the meningococcal changes. Okay, so Men B, Bexsero, is now NIP funded for these groups. Aboriginal and Torres Strait Islander children up to the age of 2, those with specific health conditions. There is a catch-up for Aboriginal and Torres Strait Islander kids up to the age of 2 for the next 3 years, okay? So the main thing is to check the vaccine history and the air, particularly as, oops, it's going a bit speedy, because people may have moved from South Australia where they've actually had a program in their state for a little while now. So just check that. So this is for the kids under the age of 2, okay? How many doses you really need depends on the age at which you start and whether you have risk conditions, okay? So if you start between 6 weeks to 5 months of age and you have a risk condition, you need obviously 1 extra dose. So that's the 3+1 schedule. If you're 6 weeks to 5 months and you don't have a medical condition, then you just need the 3 doses. That's a 2+1 schedule. If you do start between 6 to 11 months, regardless of your age, you need 3 doses, and more than 12 months, so regardless of your medical condition, yes or no, you need 2 doses, okay? And those 2 doses are about 8 weeks apart, all right? Important to remember that because this particular vaccine can cause some fever, we give prophylactic Panadol with each of those doses. And then my thoughts are to give a dose before you give the vaccine, and then probably a couple of doses for the next 24 to 48 hours after that, if you can, just because that's when the fever will come on in that first 24 to 48 hours. Okay. In terms of Men B and ACWY, there's still an NIP funded Men ACWY at the age of 12 months and for adolescents. But the NIP funded Men B and Men ACWY is for people of all ages with those following conditions, and we talked a bit about that before. If you've got functional or anatomical asthenia or complement, or you're on that particular drug, okay? And Men B is funded for those under the age of 2, as we talked about earlier. Okay. Now, if you're in increased risk with an at-risk medical condition, then again the story really is depending on how many doses you get, depends on the age at which you start it. Okay. Essentially, if you've got one of these at-risk conditions, you need the extra dose. All right. And we talked about that before. It's a +1, it's the booster dose and prophylactic Panadol with Men B, as we've shown before. This is all the available, not all these, a lot of the available resources, again on the Immunisation Handbook, Commonwealth website, NIP, and at the spleen.org, it's got some quite useful websites as well. There are consumer resources for Men B. You can see here available at the health.gov.au for you to access. So the key messages are that as of the last 28 days, all Aboriginal and Torres Strait Islander kids up to the age of 2 are eligible for the Men B under the NIP. There's a catch-up program, and the number of doses that they get really depends on the age at which it started, okay? Now, also, if you've got these health conditions that we talked about, then you get extra doses of Men ACWY as well as Men B. But if you're not, if you're just a healthy child, you still get your normal MenACWY at the age of 1. And do look at their vaccination history on the air. So hopefully that's fairly clear with the meningococcal story. MenACWY, routine dose at still the age of 1. Men-B routinely now under the NIP for under 2-year-olds for Aboriginal and Torres Strait Islander, and under the NIP you can get those extra doses if you've got the medical condition. Okay. A little bit about the Hep A schedule, and Katrina showed you that has been a success. So there is a schedule change for the Hepatitis A. This is not so relevant for Indigenous kids in New South Wales, but there might be if they've come from interstate, or they're moving interstate, I suppose. And there's been a bit of a change in the timing of the Hepatitis A dose. Instead of in the past it being given at 12 months, it's now being given at 18 months. And the second dose, instead of 18 months, is now at 4 years. Okay. And as Katrina showed you, that vaccine is working quite well. Okay. I think the thing is to think about Hep A. If you're going to be moving and working in those states, think about it in the Aboriginal and Torres Strait Islander, and there will be a bit of a transition phase where those who probably, presenting for the 12-month catch-up dose just defer their Hep A until the age of 18 months, and then pretty much the second dose from the age of 4, anytime after 6 months from the first dose. The new NIP funding for the Hib vaccine. Hib vaccine is now NIP funded. As I talked about before, people that have a problem with their spleen. Sickle cell disease is a problem with your spleen and other hemoglobinopathies, okay? If you are not vaccinated in infancy with Hib, or you're incompletely vaccinated and you have one of these conditions, then you should get a single dose of Hib, okay? But booster doses are not required, and it is funded on the NIP, except for those that have had a hematopoietic stem cell transplant, but it is recommended, okay? So if someone turns up, they're an adult and they've lost their spleen and they never had Hib vaccine as an infant, give them a single dose of ACT-Hib, okay? Again, there are lots of resources, the Hepatitis A and Hib resources available on the website. Now we'll go on to the pneumococcal story, and hopefully the changes that have been made will make it simpler for everyone, but we'll pause for another poll if we can.
Yep, so the next poll should be on everyone's screen. Asking about the PCV 13 vaccine, otherwise known as Prevnar 13. The votes are coming in fast this time. I'll just give you a few more seconds. Okay, that looks like we've nearly got everyone voted there. So I'll close that poll off and share the results with everyone. So you've got a bit of a mixed bag there, Nick, of answers, with 70 years getting the most responses. So I'll hide that now for you and back to you.
Okay, great, thank you. Okay, so same sort of story. Children and adults that have increased risk of pneumococcal disease, they're ones we're targeting for the vaccines. We're also targeting those Aboriginal and Torres Strait Islander children in those states, and then all Aboriginal and Torres Strait Islanders over the age of 50, and then all non-Indigenous adults over the age of 70, okay? So like I said before, there was that old category A, category B, and I don't know about you, but it was really confusing for me. So hopefully it'll be simpler. And this table you won't be able to read. However, what we've tried to do here is to look at the eligibility for the NIP and you'll see a list of the conditions down here that mean you're at increased risk of pneumococcal disease, and then it's broken down by age and whether or not you're eligible for it under the NIP. Oops. Okay. So we'll go through this in detail, but I might just slip through the next one here. So the universal childhood pneumococcal vaccine schedule, okay, that's healthy non-Indigenous children and Aboriginal and Torres Strait Islander children living in those states get the routine 2, 4 and 12 months, okay? So that's what we're doing already. That continues. First dose around about 2 months, although it can be given earlier at 6 weeks, and then a 4-month and a 12-month dose. So that's the healthy listed there, okay? Now, if you're a kid under the age of 12 months and you have at-risk condition, or you're Aboriginal and Torres Strait Islander children living in those states, you get 4 doses. You get a 2-month, 4-month, the extra one at 6 months and a 12 months, plus you get a Pneumovax 23 at 4 years and then a second dose 5 years after that. Okay, so they're getting extra doses. Now these is most Katrina showed you to try and improve the protection for the Aboriginal and Torres Strait Islander children and those who have at-risk conditions. So that's that one. If, however, the person is over the age of 12 months, or they're an adult or an adolescent with at-risk conditions, then they just get a single Prevnar 13 at diagnosis, followed then by 2 doses of the 23-valent Pneumovax. Okay, that first one can be given 12 months after the PCV, or at the age of 4 years, whichever is later. And then the second dose at least 5 years after that. So, so that hopefully makes some sense. The number of doses that you're required a little bit depend on the previous doses. Okay. Now the Aboriginal and Torres Strait Islander adults without a risk condition, they get a 13-valent Prevnar at age 50, and then they get 2 doses of Pneumovax 23, one 12 months after that 13-valent, and then one 5 years after the first Pneumovax, okay? Non-Indigenous adults without a risk condition, okay? That's a single dose of Prevnar 13 at 70 years. Now, people have said 70 on the poll, they were right. This is designed to align to the Zostavax schedule point at 70 years, okay? So we were in the past giving the Pneumovax 23 at 65, but now we're just giving those people Prevnar 13 at age 70. That single dose is for non-NIP, is NIP funded for all non-Indigenous people. And I think we'll talk about that, the dose intervals between previous ones. We'll come to that in a second. Okay. Again, lots of information there available on the Spleen Australia NIP and ATAGI statements to help you. So the key messages, take-home messages for children. Healthy childhood NIP remains the same, 2, 4, 12 months. Aboriginal and Torres Strait Islander or those with at-risk conditions, they get 2, 4, remember that 6-month dose and a 12-month dose, and then the extra 2 doses of the 23-valent pneumococcus. Okay, look on the vaccine history on the air to see what they've been given in the past. Hopefully it'll be there. For the general population, Aboriginal or Torres Strait Islander at ages 50, they get the 13-valent plus the 2 Prevnars. We now start at the age of 70 getting the 13-valent. This replaces the previous 65 and is aligned to be the same time as the zoster vaccine. And look on the register to see if they've had it. There are some catch-up tools available. The immunisation catch-up calculator for the handbook is live, but it's only focused on 10 years and under, okay? So it won't really help you for the adults. The PneumoSmart tool is being updated at the moment, and that hopefully will be, we might let people know when we think that that has been done as well. I'm hoping that these next few clinical case examples will give you a bit of a flavour of trying to put this all together. So here's an Aboriginal child aged 12 months, okay? So they were born in New South Wales, they're Aboriginal, they're up to date with their NIP vaccines, but they've not had meningococcal B or flu, okay? So at the age of 12 months, they would get Prevnar, they'd get their MMR, MenACWY and MenB, and flu. So you can see there, that's 5 vaccines. They will then get a second flu dose, which is because it's the first time they're getting it at age 13 months. Because they need 2 Bexseros, they get a Bexsero at 14 months. We've given you another option. This is the flu for the year after, okay? At 18 months, they get an MMR, a Hib and a DTP. And then at this 4-year mark, they get their DTP as well. So the key thing is this one here with extra MenB thrown in here and the 2 doses and the flu as well. Okay. A healthy non-Indigenous adult who's 65 years of age, non-smoker, rarely drinks alcohol, had a previous DTPA 3 years ago. They were at 65 going to get this Pneumovax. Well, they don't anymore. They can be told, nope, don't need to get that. Go away and come back and get that Prevnar 13 when you're 70, and we'll give you the Zoster one at the same time. However, they can get the annual flu, okay, from that time point. A non-Indigenous adult with a medical condition. Unfortunately, this person had a 35-year-old had an emergency splenectomy, okay. No history of Hib vaccine or meningococcal vaccine. What this particular male needs is, remember the encapsulated organisms, pneumococcus, meningococcus and Hib, needs extra doses. So we give a pneumococcus 23, Nymenrix, so MenACWY and MenB, a Hib and a flu, all right. Because of the age, they need 2 doses of the MenACWY and the MenB, and that's their second dose there. And then this pneumococcal, the 23-valent one, given a year later, okay? And then they go on to get the annual flu shot, and then they get a booster dose here of MenACWY as well, okay? So there's lots of information available, as I mentioned. We won't go into this. There is this very nice poster which was done from the Murrumbidgee group. A couple of FAQs for you. Can Bexsero be co-administered with other vaccines? Yes, it can. They can get injection site reactions, particularly Bexsero and Prevnar 13. So if you're going to do it, give it about 2.5 centimetres apart from each other. Obviously, they're 12 months of age, so we prefer to use the upper limb rather than the lower limb for Bexsero or Prevnar, because we like the kids, if they get a sore leg, we don't like them to be limping around them, unfortunately, if they do get a sore leg. Is Bexsero license can be given at 6 weeks of age? Yes, it can, and can be given with other vaccines. Are Aboriginal and Torres Strait Islander children aged over 2 years eligible for free catch-up? No, they must start that dose under the age of 2. So that's only available, that catch-up's only available for the next 3 years, okay? So think about that one. And if the child has their first dose of Bexsero at 23 months, is the second dose still funded? Yes, it is, okay? If they meet the conditions or they're Aboriginal and Torres Strait Islander. So if someone says to you when you turn up to get the Pneumovax 23 at 65, and you say, oh, no, you don't need that, come back when you're 70, they'll say, why? And they will say that it's a better vaccine, the 13-valent one, okay? And the real risk period is from the age of 70 and onwards. So what we'd like to do is give you the better vaccine at a more, when I say better, more immunogenic vaccine for those 13 serotypes probably when you get to 70 years of age and you're into the higher risk period. So it's closer to the time you get it. And the reason they might say, well, why don't I just have it now? You can say, well, the effectiveness wanes over time. So we want to give it to you closer to the time that you're in that risk age group. And that's what we've tried to show here. Okay. And it is very good as I mentioned, it's a very good vaccine, particularly for the nasty pneumococcal bacteremia, which is the bloodborne infections. Okay, so that's one we really want to worry about in the over 70s. Can providers give the Prevnar 13 with Zostavax? Yes, they can. You can give it the whole lot at the one time if you want. Okay. So can you get the funded 13 valent even if you've already had a 23 valent? Okay. So I'll just walk through this one. Once they get to 70, they do get that single 13 valent vaccine. Okay. If, however, they did get the previously 23 valent vaccine, then you have to wait at least 12 months before you give the 13 valent. So if someone turns up at 70 and they said, yeah, I got the Pneumovax 23 at 65, say, great, I'll give you the 13 valent one now. If, however, they said, I was a bit late, I got the Pneumovax 23 when I was 69 and 6 months, and I'm now here for the 13 valent, you say, no, you've got to wait at least 12 months until after that 23 valent vaccine, okay? So that's an important time consideration there. So this is another question. If an Aboriginal or Torres Strait Islander child received 4 doses of this 13 valent pneumococcal conjugate vaccine and then had a diagnosis at 5 years, what we want them to have had is at least another Pneumovax 23 5 years after the previous one. Okay. And have a look on the register and just try and get an understanding of how many previous doses they've had and those other conditions there. Overall, as you can see, we quite like people to have 2 lifetime doses of the 23 valent one. Okay. Why are some of these vaccines NIP funded and others aren't? The main ones that are funded are because they've gone through the PBA assessment and they've been shown to be both cost effective and effective in terms of, reducing disease, okay? And as Katrina showed you earlier, a lot of these conditions, particularly these pneumococcus and meningococcus, there are target groups that we want to protect against, okay? If, however, people do want to get them, they can, but they may not be NIP funded, and it's important to opportunistically discuss all the appropriate immunisations to see if there's a cost there. Okay. Final take-home messages. We talked about Aboriginal and Torres Strait Islander, and Katrina gave you a great talk earlier. Try and think about whether people in your practice are at risk. You've got lots of information and hopefully some information from this talk to know about the schedule changes. Look at the New South Wales health schedule, put things on the register, and there are lots of infographics there as well. So if you haven't dived into the handbook, I would recommend it. It's even though it's online, you can't sit, you can't sort of take the hard copy and then pour over it in the coffee shop, but you can look at it on your laptop or on the computer. It has got some very good graphics now than it had before. Sky website is continuing to grow and there's lots of information there. So if people want to access that, particularly your patients, you can direct them to that one. A list of resources there, and so I shall stop there.
Okay, so if anyone's got any questions for Nick, can they type them in? And I think, do we have a couple there, Michelle?
We do have some questions. Thanks, Katie. First question is, for vulnerable people, do they need a second flu vaccine this year if they've had one earlier in the season? They need to have a repeat during the year.
Yeah, we sort of talked a little bit about that. The general rule is no, they don't need a repeat vaccine. The pregnant woman who, I'm not sure we got to that in this talk, but a pregnant woman who got the flu vaccine, so let's say a woman turned up in February, March, and she wasn't pregnant and she got a flu vaccine, but then she gets pregnant later that year, and so she's now pregnant in June or July, and she says, well, I'm now pregnant, should I get the flu shot? In that particular story, we probably would say no. You've already had a recent dose this year. and you're not going to be delivering until, 9 months' time, obviously. So that will be from June onwards, probably not till sort of March, April next year. In which case, you should probably get the 2021 flu vaccine in the later stages of your pregnancy. If, however, someone has chronic medical disease like, obstructive pulmonary disease or something, I know people are giving a second dose, but it's not routinely recommended. And for this year, may not be that useful, particularly as there's very little flu around. And if we continue to do the social distancing and isolation, we may not see any flu at all this year.
Okay, thank you. Thanks, Nick. Next question on flu again. For children, why do children need less than 10 years, 6 months to less than 10, why do they need 2 doses of flu vaccine for the first year they have it?
Yeah, the main reason is because they haven't had a chance to be exposed as much to other people to natural flu. So what the clinical trials have showed in those kids that they're younger ages, that they're a little bit naive to influenza. So there's a lot of evidence to say that what we'd like to do in a sense is prime the immune system with the flu antigen and then give you the booster dose in your first year. Now, I'm not sure how many people that actually do that 2 doses in their first year, to be honest. I think it'd be an interesting thing to look at. But the idea is to sort of prime the immune system the first time you see flu, and then to boost it with that extra dose in your first year. Thereafter, your immune system has sort of been recognised or been shown to see flu antigen, and therefore in subsequent years you just need another dose. It's what we call an imprint. You get an immunological imprint of the flu antigen on your immune system.
Thanks, Nick. And if a child had 1 flu shot, if they're less than 10 years of age, if they had 1 flu shot last year and didn't get a second dose, do they just have 1 dose the following year, or do they need 2 doses the following year?
No, just the 1 dose. Yeah.
Thank you. Thanks, Nick. For a child that's less than 2 that's coming in for their dose of meningococcal B, do they need, if they haven't had Panadol, what happens there?
So if they've not had Panadol,
they haven't had a Panadol dose on board.
Yeah, they'd be okay. They could. So you're saying I don't think I would just try and give it, and if you can, wait half an hour or so. So there's a bit of Panadol going through the system. In actual fact, the fever is quite quick, and probably around about the 8 to 12 hour mark after this vaccine. So, I wouldn't turn them away, but I would just give them you could give them a meningococcal B vaccine at the same time almost as the Panadol.
Okay, thank you. A healthy non-Indigenous person who's had a pneumovax at age 65, do they now get Prevnar at age 70?
Yes. Yep.
That'd be the pneumococcal 13?
Yes, that's correct. Yep. Prevnar 13. Yep.
Yeah, okay. Nick, is there a logical reason for not funding replacement vaccination after marrow transplant?
No, not that I could see. The main thing is, as I mentioned, that to get onto the NIP, it has to be shown to be cost effective. And so if the company didn't put up evidence to demonstrate cost effectiveness, then it wouldn't get onto the NIP. It wouldn't be assessed by the PBAC. So it's all about if you can demonstrate that the vaccine cost effectiveness is okay, then the PBAC will suggest that it can go onto the NIP. But it may not have been put up as one of the things they wanted to get, the company was interested in getting funding for. Still recommended, but the people just have to pay for it, unfortunately.
God. And can you give an update on the progress to the availability of the non-live zoster vaccine?
Good question. I don't know that one. You're talking about the Shingrix one, which is the GSK one. I'm not sure. We can probably take that one on notice and get back to the group. It would make life a lot simpler if we had that vaccine, I agree.
Yes, yes. If you've got a person that's aged over 70, say they're 71 years, now, for example, who had pneumovax 23 at 65, would you still give Prevnar? Yes, you've answered that, so that's all good. think. What's the next one? Is the additional Prevnar dose needed in New South Wales for Indigenous children without any risk?
So say that again. Is the
additional Prevnar dose needed in New South Wales for Indigenous kids with no risk?
No, it's just for the kids in that state. So I think if I go back to it's on the slide. It's just for the ones in outside of New South Wales. Where is it here?
Yeah. Should we recommend early zoster for people with a history of shingles, say more than 12 months ago, who are aged less than 70?
So that's the question about the, can you see that?
Yes, we can. Yep.
Yeah, okay. So there's your question about the Aboriginal and Torres Strait Islander in living in these states here. So next question was?
Sorry, probably jumped in too quickly. Should we recommend earlier zoster for people with a history of shingles over 12 months ago who are aged less than 70?
Good question. I probably would wait till 70, to be honest. The thinking is that you don't want to get zoster when you are older than 80. What we know is the shingles you get the older you are, the more nasty it is. But what we don't know is how long the zoster vaccine immunity lasts. So it's probably better to give it at the right age than to just go a bit earlier. Would be my advice. Is that answering it? I hope it's fairly clear. But you want, because the immunity probably wanes with time after the zoster vaccine, we don't want to go too early with it. And if you have an episode of shingles anyway, you're probably going to get some little immune boosting. So by the dose of shingles itself should give you some protection. Now, I know people say, oh, I kept getting shingles every 6 months. They probably would need to just think about, is there any other reason why that's happening? But so it's a long-winded answer, but my advice would be don't give it too early, because we want that vaccine to be particularly working when you're in your 80s.
Yeah.
Or 90s even.
Meningococcal B dose 1 at 12 months of age with other scheduled vaccines. Can I just give dose 2 when the child returns at 18 months of age for their other scheduled vaccines? And does it have to be 8 weeks? Can it be more?
Bit hard to see these. I can't actually see them written down anywhere, but
no.
So
do you want me to read it again?
Yep.
Okay. Meningococcal B dose 1 at 12 months of age with other scheduled vaccines. Can I just give dose 2 when the child returns at 18 months of age for their other scheduled vaccines? And does it have to be 8 weeks, or can it be more?
So you do want to give, just trying to find the Aboriginal ones, probably not one here, but you do want to give, you don't really want to delay the 12 months dose to 18 months. So you really want to give that first dose on time. Are you talking about someone that's healthy or at risk?
I think this would be a healthy Aboriginal, I'm thinking.
A healthy Aboriginal, yeah, so that's this one here. So they're getting this Men B at 12 months. Are you thinking that you would delay this first one to then not give 5 on the one go? Now, that's probably a reasonable approach. I probably would, depending on the time of year, you might not need the flu shot. Okay, so then you're getting down to 4 vaccines. And you could delay one of these by a couple of weeks, but it means extra visits, and that could be a problem. But you don't really want to delay the receipt of these ones here. I hope you can still see my slides. You don't really want to delay the receipt of these ones for too much beyond the 12-month mark.
Great. Okay, thanks, Nick.
Thanks,
If
Nick.
I understood the question all right.
I think so. Well, we'll take it on notice. If we haven't answered it, we'll certainly get some feedback from the participant. The next question is, I think the product information on Zostavax says Pneumovax 23 should be separated by a month as it may reduce effectiveness of Zosta. Is this right?
Yeah. I think ATAGI felt that it was okay to co-administer them. So sometimes they go against the product information. I don't know the specifics of any degree in reduced immunity, but it's a good question. But from what I understand from the ATAGI statement is you can co-administer.
Thank you. Is it okay, this is back to Bexsero, is it okay to give the second dose of Bexsero at 18 months if the first dose was given at 12 months?
Is it okay? Yes, it is okay. Yep.
Thank you. Can you go back to resources page? Can you go back to the resources page, please? I think we'll just ask if we can circulate the slides to the question that, to the person that was questioned. So we'll get slides. What is the youngest age for Zoster being given if they've had a previous serious case of chickenpox? We're going to set that, haven't we?
I think it can. I think it's registered from 50, but funded from 70.
Yep. Okay. What is the interval between doses for meningococcal B if the child is starting a catch-up under 1 year of age?
Okay, we'll just try and pull up this one here. So sorry, what is the Men B, the interval?
What is the interval between doses for Men B if the child is starting a catch-up under 1 year of age?
So it depends on, you can see here, they get the usual gap is a minimum of, for example, if you're starting here between 6 to 11 months, they need the 2+1. The minimum interval would be ideally at least 4 weeks. So you would give dose at 6 months, 8 months, and then probably I'd give it at the 12-month mark. That's how I would do that.
Thanks, Nick. Next question. People with severe COPD no longer qualify for pneumococcal vaccination under the NIP. This doesn't seem sensible.
Yeah, that you can't quite read it here, but it's in one of these ones here. I'm not sure how to make that any bigger. So these are the ones that this is the one that people are worried about, this COPD and chronic emphysema. It is certainly recommended, but not in the NIP. I don't know how to answer that one. It probably didn't make the cost effectiveness, again, the PBAC. Is it logical or sensible? Possibly not, but it's certainly recommended, but just not funded.
Okay, thank you. Maybe just a couple more. Have we got time for another one?
Yep.
Okay. If a patient has had more than one Pneumovax 23 doses and are now 70 years of age or older, do they still require Prevnar 13 or are they covered with the Pneumovax?
Yeah, I would give, they're probably covered, but I would still give them the Prevnar 13. It's just to be honest, the next generation pneumococcal vaccine, because of the way it's made, you get a better immune response to the pneumococcal antigen. And so even if you've had 2 previous pneumovaxes, I would give you the Prevnar 13 at 70. Yes.
Okay, thank you. For aged care, so do you think that the mandatory influenza vaccine will stay in the future for anyone entering an aged care facility after 2020?
I think it probably will, yes. Yeah.
Thank you. Aboriginal and Torres Strait Islander patients now have Prevnar 13 of 50 years of age or older, followed by Pneumovax a few months after that, and then another Pneumovax at least 5 years after. What happens if they've had multiple Pneumovaxes as per the old regime? Do they still receive a Prevnar?
I would still give them the Prevnar 13, but they may not need any more 23-valent pneumococcal polysaccharides because we like to give you 2 lifetime doses usually.
Thank you. And why is the Prevnar 13 better than Prevnar 23?
The way it's made, the Pneumovax 23 is basically the sugar capsule of so the bug is Streptococcus pneumoniae, and it has this polysaccharide capsule, which is like the outer wall. In the Pneumovax, what they do is they take that polysaccharide capsule of the 23 common pneumococcal types, and they put that in the vaccine. The body recognizes the sugar capsule and makes antibody, but it doesn't make what we call really good quality antibody. That's what Pneumovax is. In Prevnar 13, they take that sugar capsule from the 13 serotypes, and just to keep you on your toes, there's a Prevnar 20 in the pipeline as well. But they take the polysaccharide capsule from the 13 common pneumococcal serotypes, and then they link that to, they do what they call conjugate it to either a diphtheria toxoid or a tetanus toxoid. And by linking it chemically to these other bits, you get a better immune response. The body recognizes it as foreign and you get better antibody. You get a little bit more antibody, but you also get better quality antibody. So antibody that is more effective and efficient. And so if you see the real pneumococcus in your life, you've already got a high quality antibody on board and therefore you don't get the disease. I hope that's reasonably clear.
Yes.
Yes, thanks. Thank you. I think we've still got quite a number of more questions, but I think we better wrap them up and we'll just take them on notice and get the answers back to the participants later on.
Happy to do that. We can, if you just give us a list of them, we can provide written answers that we can share throughout the group. Yeah.
Fabulous. Thank you.
Wonderful. Thank you so much.
Questions,
yeah,
everyone.
thank you for all the questions, and thank you, Nick, for answering those. We'll now move on to our next presenter, which is Lauren Dalton. Lauren will be speaking on accessing AIR through PRODA account. Lauren is the Immunisation Liaison Officer, PHN Immunisation Support Program at NCIRS. Lauren has a background in public health and has been working with NCIRS since 2017. Before this, Lauren managed the population health portfolio, including the immunisation portfolio at the South Eastern Sydney Medicare Local and Central and Eastern Sydney PHN, and before that at the Royal Australasian College of Physicians in Health Policy and Programs. In addition to these roles, Lauren has been involved in a number of AIR data quality studies. And I will now pass you over to Lauren.
Great.
Just make you presenter, Lauren.
Thanks.
And we should be away. Thanks so much, Lauren.
No problem. Thank you. Thanks everybody for having me. I'm just going to share my slides. So just click on that. Just double checking that you can see all that clearly.
Yep, we can see and hear you, Lauren. That's wonderful.
Great. Thanks everyone for having me. And I'd also like to acknowledge the traditional owners of the lands that we're all meeting on. And for me in Sydney, I'm in the southern suburbs, it's the Darawal people. So
I'd like to thank Western New South Wales team for inviting me tonight, and I try not to keep it too long given the interest in time, but and it's always a bit of a tough gig to follow, Nick, and a tough gig to talk about data and data quality in the register, but we'll see how we go. So look, I'm just going to cover a few things tonight, just a little bit about the background of what the data is used for on the register. Just a quick snapshot of the practice software and where we're at given the schedule changes that have just occurred. Then I'll give you a little bit of detail around accessing the register via PRODA and HPOS and delegations. And for some of you, you'll be all over this. For some of you, you might be sort of in the midst of moving over, and for some, it's sort of time to have a think about where to from here, and a little bit about the AIR report. So just a little bit of background here. You know, data, I mean, data is the key to everything in the work that we do, but on the register, it is used for a number of reasons, and I guess one of the biggest ones is it is there to support clinical decision making and making sure that the person is appropriately vaccinated. Oh, sorry, I've just changed something there, sorry. It's also used for measuring immunisation coverage, monitoring the effectiveness of vaccines and vaccination programs. We use it for informing policy and research, and a lot of the work that we do at NCIRS uses the data from AIR for those purposes. It's also used for identifying parts of Australia at risk during disease outbreaks, which is very important. And more recently, over the last few years, we've seen it being used for assessing somebody's eligibility for family tax benefits and childcare subsidy payments. And of course, people need up-to-date statements that are available through the register to assist facilitating entry into childcare and school. And more recently, we're seeing it being used for those seeking employment, particularly in healthcare and for travel. So it is really important. And I think one thing that is really good to know and to promote is that you know, the register that we've got here in Australia is really world class. There's very few countries around the world that have a national register, so we should be really proud of that. And you know, it is we do get asked to present internationally about our register, and certainly you know, there's many countries that have modelled their registers off ours, so we should be really proud of that. But at the end of the day, it's only holding the data that we send to it, so it's really important to know it is a whole of life register. It records all vaccines given to all people in Australia, and all those encounters should be sent. And you guys out there in Western New South Wales should be really applauded for your excellent coverage rates and really obviously then sending as many immunisation encounters as you can. And traditionally, you know, we are seeing that for the childhood encounters, but remembering that adults is a really important component now, particularly when we're seeing changes to the schedule all the time, that those adults still should have their encounters reported in various settings. So whether that's in general practice, in community clinics, in pharmacy, in workplaces, and we would encourage all providers to be sending the information to AIR. So this screen, and for those that when I was out at Dubbo and Orange a few years ago, we did present something similar, and this is from last year, some data that happens on a daily sort of occurrence at the register. And we had an update yesterday actually, and that data hasn't been published yet and will be shortly, but certainly these numbers have changed. But you know, on average, this time last year, they were seeing about 36,000 immunisations submitted just through practice management software alone, another 10,000 going through the AIR site, and a few manually, but a large percentage of those were also being pended because of data errors, and lots of phone calls from providers, from individuals, and lots of paper-based forms. And certainly, I think it just gives us sort of a good snapshot that the amount of volume that is going through to the register every day. And also just a little highlight here that this table was from a day in August, but in May we were seeing 152,000 vaccines submitted through practice management software, sort of right at the beginning of flu season. And you can be assured that those numbers were substantially increased this year, particularly with the amount of flu that was given and the amount of flu that's now been reported by other providers, including pharmacy. So I just wanted to sort of highlight just a couple of things around practice software, which is so heavily reliant in your settings and making sure that that data is going across to the AIR. So with the schedule changes that happened on 1 July 2020, often you'll see, and we are expecting some changes to and updates to the practice software that you used. not every practice software is automatic. So you'd need to check that with your software company, a bit like the apps on your phone. Sometimes things just update, but sometimes you have to press the update button. So that's really important to understand. And as I just flagged, we are expecting some software updates for the scheduled changes to coming in soon. Particularly had some just recent advice from best practice and medical director that will be expected before the end of the year. So hopefully sooner rather than later. And I know that for those working in, in sort of primary healthcare, you're getting a lot of communication correspondence every day, but please keep an eye out on that correspondence that's coming from your software provider about when the updates are available. But in the interim, if you are seeing children, particularly those now that are receiving those additional vaccines that are funded, please use the other vaccine given box, and then you'll be able to populate and send that information across to the register. So here's just a little snapshot on the different softwares and what's coming up. So best practice here advised that with the updated schedule changes that are coming in and the reflections that will be made to their software, you'll need to be updated to the JADE SP3 version and those ones there. But as this gets updated, I'll certainly communicate that with Michelle and the team at the PHN and the PHUs, and they'll get that advice out to you. But please just do keep an eye on things. And maybe just check who is actually responsible at your practice for upgrades to your software, a bit like cold chain management. You've got someone for cold chain, maybe also think about having someone dedicated to just to be aware that practice software is changing all the time, and I'm sure you see that with the medicines updates that happen as well. So just a little bit of summary around the practice software tips, and this is nothing new to you guys. I'm sure you're doing it all the time, making sure you've got the latest software. It's really important that the patient information that's held in your software matches the details held by Medicare. And one thing to ensure that DVA patients have a Medicare card number listed in the software, because that's what's used to match those records in the back end by the register. Every patient, every DVA card holder does actually have a Medicare card number. They might not ever use it and they might not have a card, but you can actually look them up for their Medicare card number via HPOS online, and you can do that. And you can also check their demographic details to make sure that they are matching. So despite someone telling you, particularly those who use medical director software and practice software data, we know that those encounters don't get transmitted to the register automatically if there is no Medicare card. So making sure that that field is completed. Always use the immunisation tab to record encounters. Don't free text, otherwise the software doesn't know that an immunisation has occurred. Checking the vaccine name is correct and sequence number, and I'm sure you're all doing that as well, particularly given your rates are so high. Just when we're talking about immunisation history, if you are recording or you are seeing a patient that's had some vaccines given elsewhere, you can still enter that in your practice software. You can tick the little box that says record as given elsewhere. So it won't be duplicated as a duplicate entry on the register. Your software won't send those to the register. But what it will mean is that then your patient history is completed, and it will help with scheduled dose numbers when they're coming in for subsequent vaccinations, particularly when they're children. So we want all vaccine encounters sent to the air. Preferably doing that daily is great, and checking your sent box that they've gone through. So I think that's just sort of a little bit of information about software. I've got a poll now, so I'll ask the team there to bring that up. So we're about to move on to this PRODA space. So I think I've got the question there.
Yep, so we've launched the poll, and the question is, I access the AIR site. Do I need to register for PRODA?
It's a good question, isn't it? I think PRODA means PRODA means different things to different people, and some people would, as I said, would be very familiar with it. Some may be new, and some thinking I don't want to know about that right now or in the midst of a pandemic. So
yeah, we'll just give people a little bit longer.
Sure.
Righto, so we might close that there. and I'll just share the responses with you.
Mm-hmm.
So you can see it's a bit of a mixed bag again for that one.
I actually can't see those responses. It doesn't come up on my screen for some reason.
Okay, well, so we've got 62% saying yes.
Yep.
They need to prove their identity. 13% say no, the organisation will organise that. And you've got 26% saying PRODA. I have no idea what that stands for. So a few in each one.
Yeah, that's great. Well, the correct answer is the first one is yes, you all need to do something. I think I might have just lost my, can people still see my slides? They've just
so we're back to your slides. Yeah, we're back to your slides now, Lauren.
Okay, I'm just going to hide myself.
There we go.
Oh.
Yep.
Okay, great. Yes, so the answer is yes, and I'll get to that in a minute and the reasons why that. And for those who said my organisation will do it, the organisation does need to do something, but you as an individual also needs to do something. So what is PRODA? Well, that's a question that we get asked a lot, and obviously I don't work at the Services Australia team, the old Department of Human Services, but I have spent a lot of time with them over the past few months, and hopefully I'll be able to give you a good snapshot here tonight. But PRODA is really, it's an identity checking system. So it's just that, it's to make sure that the government, you're accessing the AIR site and other functions through HPOS, and that contains significant patient information. So what PRODA is that it's us, well, it's not us, but it's checking that your identity has been confirmed and you are who you say you are, and you also are the right person to be accessing that patient information. So I like to use the analogy that's a bit like going to a bank. You can't open up a bank account until they've proved who you are and you've produced your ID. But once you've done that step, then you can access your bank accounts. And so this is a bit like PRODA. We're proving who you are, and once everyone's happy that you say who you are and we know who you are, then you can access the AIR site, and you're able to do that because you're delegated to do that because of your position. So overall, PRODA is about better security. It is done online. The registration is done online. You don't need a paper form and you don't need to sign something and send it off. But the good thing about it is that once it's done, you can then access the AIR site from any internet connected device. And you as an individual has that access all the time. You don't need an authentication file. You don't need to change the password all the time. You don't need to share passwords, share access. So it is better all round. And there's some good instructions about how to register for PRODA. You do need some verification documents, including your license or passport, Medicare number, for example. But it is quite a simple process. You do it all online. You enter your license number, that's checked in the background, and so on. So I will get to a screen about how that's done in a minute. So it is important that people start now thinking about PRODA, and I'm going to get to sort of a step-by-step guide on who needs to do what at the moment. But you as an individual, every individual needs to register. GPs would have already have access to PRODA because they are a Medicare provider, and those documents have been checked. So it's the way it's going to move forward over the next few months. So getting you ready is the key to all of this. So as I was sort of saying, PRODA is really just identifying who you are, and once that's happened, then you can link your PRODA account to HPOS, and HPOS is the next level down to get into the AIR site and various other things that you do business with Services Australia. So you confirmed who you are, you've got access to HPOS, and then the AIR site is linked through HPOS that way. So you don't need your authentication file anymore, and that's what it looks like online. So I'm sure plenty of you are using it already, and some are familiar, some may have not moved over yet, but this is the way we're going. So this is really just a bit of a slide about where we're at and where we're moving to. So some of you may be still using, you can see here, an individual login to the AIR sites. You know, the GP might be sharing the password with the nurse, who might be sharing it with the practice manager or other staff, and really and you've got an authentication file, you might be using the GP's authentication file, or you might be using the organisation's authentication file, and sharing passwords. And then if someone doesn't put in the right password, you'll get blocked out. So it's a bit messy, but you still got to HPOS and to the air site through that method. But the next method now is using PRODA. So you as an individual will have your own individual login and your own password. You will then be linked to HPOS, whether you're linked via the organisation that you're working in or the GPs that you're working with, and accessing the air site that way. So I'll get into a little bit of detail about that now. So I've just put a few questions up here that get asked quite a lot. So I work in general practice. So how do I access the air? Well, if you're a GP, you should be using PRODA now, and that's been live for quite some time now, and that is linked to your HPOS. And then the air tile comes up on your HPOS screen, and you can access the air site that way. So if you haven't activated your PRODA, or you don't know where you're at, I do have a screen about the contact details, but that's where you should be accessing it now. But if you're a practice nurse or a practice manager, well, the good news is that you can start now accessing the air via PRODA and HPOS as well. And I'm sure Michelle has helped many of you out there start accessing it that way via delegations. So the way that happens is there's two ways, but the most common way, and probably the easiest way for most practices and most practice nurses and practice managers working, is that the GPs can give you delegations to access the air site on their behalf. So you would still log in as your own self into PRODA, and then the GP would have delegated for you to be able to act on their behalf and to complete the task on the air site. So it's similar to other HPOS delegations. It's just acting on the air. If you've got, and I'll get to the question in a minute about if you've got more than one GP. So as I was saying, there is a few options, but delegations is the best option probably, and the simplest one in general practice. But if you've got a complicated GP practice where you've got 10 GPs and you've got different locations, you can also have PRODA for organisations, and that is available, but that does require organisation registration, and you can't access the 10A reports, which can be quite helpful when you're following up overdue children. So I'll get to that in a moment. So the steps are for all staff, you need to register for PRODA. So that is to prove who you are and show your identity. And once you've done that, you'll get what's called an RA number, and you need to keep that RA number and the login details that you logged in with. So that's generally an email address or something of the like. The GP, who already would generally have PRODA set up and a link to HPOS, they have that air tile will appear. And then GPs can actually nominate a delegate. So they can link the delegate to the RA number. So Dr. Smith might like the nurse to have delegations. And so then they'll put in the nurse's RA number and link to their account. Similarly, the nurse or the practice manager might want to get on the front foot, and you can actually log into PRODA and HPOS, and you can actually request delegations of your GP to air. So you can send them a request as like they can set you up. You can also ask for the request and they can follow the prompts. So every person will only be ever issued with one PRODA account. So that's the one account, and it can move with you. So it will move with you wherever you're employed. So if you're a practice nurse or a nurse and you're working at one practice one day, and you might work at another practice on another day, or you might actually work at the community health clinic, or you might also work at the public health unit doing school-based vaccinations, or you might work at a pharmacy doing some as a nurse immuniser, you've still got your one PRODA account. And what can happen is that whichever organisation or GP or immuniser, medical practitioner you're working under, they can actually give you, nominate you for you to have access. And once you log in, you can choose who you're acting on behalf of. So one day you might be acting on behalf of Dr. Smith, and another day you might be acting on behalf of the community clinic who's got an organisational login. So it's good to know you've only ever got to worry about that one login, and then you'll have a drop-down menu to select. But just make sure you keep your RA number, and you'll give that to whichever organisation or employer you're working with to link you up. So just moving, just sort of to go over a little bit about air delegation. So I sort of briefly mentioned this about, should practice nurses or practice managers require a delegation from every GP in the practice that they are working? Well, simply, probably yes, it's a good idea, because then you can log on as the nurse and you can select which GP you're acting on behalf of. And in doing that, if you need to edit an immunisation encounter that's gone through to the register that may have had the wrong vaccine entered, or the wrong sequence number or dose number, you can then edit on their behalf, because you can only do edits on the immunisation register acting on behalf of the person who originally submitted that information. So it is good to get that information and those delegates from each of the GPs in the practice. You might notice that if you're a GP that you no longer have the secure email function through the AIR site, because this is now contained in the messages tile in HPOS, so it's actually in the screen prior to the AIR screen. But the good thing about the new HPOS messages tile, if you want to send something to the register, somebody's moved overseas, or you want to send confirmation of something that you can no longer edit, you can actually attach documents to the message, just like an email. And previously on the previous secure email function, you couldn't do that. So if you're a nurse or a practice manager, how do you send a secure email? So you just need to make sure that if you're acting on behalf of a medical practitioner, that they have ticked the My Mailbox delegates option, and then you can send emails on their behalf using the HPOS messages tile as well. And there's lots of information. I'll have a list of those at the end as well. And I'm more than happy to share these slides. I've given them to Michelle so she can send them all out to you after this meeting. So that's what the screen looks like when you're setting up delegations. There's a tick box, and we are working on some guides with Services Australia to get that out to you, just to make it a little bit easier about how that all works. So just moving along to those who may be online tonight, and I know there's a variety of people, so I'm trying to make sure that I've got something for everybody. So if you work in a community clinic or a public hospital, how do you access the AIR site? Well, probably at the moment, for those that do, you're using an authentication file, and you've got to make sure it's saved onto some computer that you can all access. But you will be moving across to PRODA, and every state and territory, each health department will set up their own processes, and they'll be talking to you individually about how that's going to be set up in your area. It's quite a process, and obviously at the moment with everything that's going on, it has been a little bit delayed, but it will be happening. So it's really the way it's expected to happen is that every organisation will set up as a parent organisation, and they'll have sub-organisations under that. But every model may be different depending on your organisation. And it does actually depend on the ABN number. So if your organisation has its own ABN number, then you can be that parent organisation. But if you sit under a health district, for example, and they hold the ABN number, then you're more likely to be a sub-organisation. So I've just got a little example here of what it might look like. And this is really just an example, just to sort of break it down for you. So you might be the health district in the area, so the Western New South Wales Local Health District, and I know there's subgroups underneath that, and that they're known as the parent organisation, and somebody owns that delegation as the parent, and that's usually the person who's registered to hold the ABN number with the Australian Business Register. And just here then, there's lots of sub-organisations, and there's probably many more than I've got listed there, but you might have various hospitals, outreach clinics, community health centres, public health units, and they're known as sub-organisations. And often the sub-organisation already has their own AIR provider number, and that would be the provider number that you're logging in at the moment with your authentication file. And then you've got the delegates. So what's going to happen is the parent organisation will set up. They might set up some sub-organisations, so it's a little bit easier to manage. They've all got their own AIR, and then they will delegate. And these individuals, they might be the CNC, or you might be the public health unit here, and you might have staff there that can access the AIR. So you're registered as an individual. You've given your RA number to your sub-organisation, which might be a public health unit or a hospital. They've linked you up, and now you can work and access the AIR site on behalf of that organisation. So you're still logging on as you, as an individual, because you've proved who you are, and then you're selecting who you're acting on behalf of. So that's where your individual login comes in here, and then the organisation has registered as an organisation that sits above that. So similarly for an Aboriginal medical service, and I know there's a few staff online tonight, so how do you access the AIR? Well, again, you need to consider your own organisation structure, and I know that they do differ in different places, but here's an example of that. So you might have the AMS here, and you're a nice sort of nice tidy organisation because you don't have various sub-organisations, or some of you may. So the AMS is the parent organisation, and there is somebody again who's owning that parent organisation and then manages the delegations, or they may then delegate this function. So it might be the CEO who has the ownership over the ABN that's registered with the Australian Business Network, and then they might say, look, I want the HR manager or the operations manager to manage all the delegations, and then they'll give the delegations to the appropriate staff. So the staff that need access, that might be the nurse immunisers there, it might be the practice manager, anybody else who's working at the practice that needs access to AIR. They're logging in as an individual. The AMS has registered for PRODA for organisations and has then given those that relevant access to the individual staff. And of course, if somebody leaves, they can then just remove the access from that organisation, or if someone joins, they can add people on. So what do you need to do now? So the first thing is that the AMS should start to register for PRODA for organisations, considering your organisation structure when you're doing that. The individual staff that are working there, you can now go online and register for PRODA as an individual number, and you'll get your RA number. So save that somewhere safe. And then the AMS, once they've set up their organisation, they can then delegate the appropriate staff to access the AIR site. So pharmacy, and I know that pharmacy is doing more and more immunisations now, and for those that work in pharmacy who are online, some of you would be very familiar with the AIR site, or you may be using practice software such as MedAdvisor or GuildLink to be reporting directly to the AIR. So you may not be using the AIR site as much as others, but again, as an immunisation provider who's registered with the register, with the Australian Immunisation Register, you can actually access the AIR site as well. And similarly, how would it set up for you? Well, pretty similar to an AMS. The pharmacy can be the parent organisation, and you own that that function, and you can delegate. And then the delegates might be, you might have a couple of pharmacists that work at your practice that are immunisers and are registered as immunisers. You may have a pharmacy technician that's doing the AIR uploads at the end of the day if you're doing it that way. So again, the individuals need to register for PRODA, and then the pharmacy needs to register as an organisation, and then you link the two together. So I've just put those steps down there. So pharmacy is registering for PRODA, the relevant staff register for PRODA and provide the RA number to the pharmacy or to that parent person. Some pharmacies most of you should have registered, for those who are providing immunisation services, with the AIR, but if you haven't done, you first need to do that, which is the IM004 form on the Services Australia website. So you need to complete that. Some pharmacies who have had access to the AIR Secure site via the authentication file, that you can still use that at the moment, but it is being phased out, and we would like you to start moving over to PRODA. And of course, every pharmacy, as well as every other immunisation provider, should be reporting all encounters to AIR, either through the software or the AIR Secure site. And we know that they're the best methods, that they minimise data entry errors and other errors, as opposed to when people are sending things through paper-based. So here's just a bit of a step-by-step on setting up PRODA for organisations. I won't go into this too much details, but first of all, you need to register for an individual account, and then you register the parent organisation, and then you're linking the two together. As I was sort of explaining some of those other slides, depending on the organisation, you might have sub-organisations, and that's really just to manage everyone and, you know, the hubs and that you might have in your area. Then you link the HPOS to your parent organisation, and then you link the AIR to your organisation. And there's certainly the AIR team is available to provide assistance, and I'll have a slide on those contact details in a moment. There's certainly lots of links online of how to do that. So you can just Google Services Australia, PRODA registration, and there's some advice there on how to register as an individual or an organisation and how to manage your organisation in PRODA. So they're quite user-friendly and easy to follow. So here's the help desk details. So depending on what you need support with, whether that's PRODA or the HPOS section or the AIR section, there's different contact details there for people that can help you along. So it's either the PRODA team, the HPOS team, or if you've gotten through those and you've got stuck at the AIR site, then there's the AIR team as well. So depending where you are up on the process, there's some different links there to help you along. But if all else fails, just Google it, or Michelle or the team there can assist. So I guess I just wanted to move on a little bit now about overdue children and how you can maybe identify overdue children in your practice. And looking from the statistics that you've got, you're obviously doing an excellent job out there, and your data quality seems to be great, because we do know that a lot of the issues relate to data quality and you know, the data entry process as well as the transmission process. But sometimes things just happen with software. And you might go through a period of time where you're getting lots of phone calls from families about children being overdue for vaccinations. You think, well, that's strange, because certainly they've had that vaccine and they're up to date, but the families are saying they've got a letter from Centrelink or they've got a history statement that says that they're not overdue, that they're not up to date and they are actually overdue. So one of the things is, just if that does happen, you know, have a think about whether those children are truly overdue, or in fact they have been had their vaccinations and they just haven't successfully transmitted those encounters across the register. So one of the things that you can do to help you along with this is, if you're working in a general practice, you can get what's called a 10A report from the AIR site. So that's a 10A report is used for those who are accredited practices, so those who've got a PIP number. If you don't have a PIP number, you can use what's called the 11B report for non-accredited practices. So for those who've been around for a while, and Michelle and I have both been around these chats for a while, that you used to get a report like this in the mail called the 32A report years ago. It used to come as a hard copy and with all your children listed, and used to have your percentage of your coverage rate for your practice, and used to be able to check those off. And if there's a child overdue, you could either fix up their encounter or call them in to get them caught up. So, but now you can still do that, but you have to do it yourself online, and it's called the 10A report. If you're a hospital or a community health clinic or an AMS, and you're an organisation rather than an individual general practice, you can actually get what's called an 11A report. So that will identify children who are due or overdue, and you can filter that report by things like ages of the children. So you might just be interested in the children who are age 1 and who are overdue, so you can put those parameters in. Or you might just be interested in children who have been to your practice in the past 6 months, who are now considered due or overdue for a vaccine, and follow them up. So what the reports are good, they are a little bit difficult to read the first time, but once you've had a look at it once, hopefully it's a little bit clearer. But one of the good things about these reports is it does easily identify those children who have got a pending status. So a pending status is a status where, you know, you've sent the vaccination through to the register and the register's received it, but for some reason it hasn't able to be processed by the register. And there's a number of reasons why that happens. Often it's because the child is not, all the information isn't completed. So they might have the date of birth incorrect, or it doesn't match the Medicare details, or the child has moved. And so what you've got in your practice software is different from what Medicare holds, and they just haven't aligned. So or somebody else, you're reporting an immunisation that's actually already been given and the dose number's the same. So it gets pended, and what happens is that child isn't considered up to date until that pending has been resolved, and often that has to be done manually by somebody at the AIR team, and often they might need to call the provider. So if you can readily have a look at your 10A reports, even if you're looking down the column that says a pending status, and if they have a Y against it, which means that they're pending, then you can follow them up and follow up those children. So there are some instructions well, this is the AIR site, and this is where you request a report, and then you select the 10A report or the 11A, depending on your situation. And then you get a series of Excel spreadsheets that contain different information about that. And as I said, the first time it's a little bit hard, but once you're familiar with opening the spreadsheets and identifying the patient and reading the line items, it does tell you the antigens that they're due for and the name of that child, and then you can match it in your practice software. But if you need help, and I'm sure many of you, it's the first time you do it, you might, Michelle and Wendy at the PHN and the PHU are available to help practices, whether you're a general practice or you're working in a hospital community health setting as well. The Central and Eastern Sydney PHN, which is where I used to work, they do have a instruction guide on how to request a 10A report and how to use one. And you can have a look on their website for those. It's under the resources, the immunisation page, and then you go to resources. But as I mentioned, we are putting together a guide to share with all the PHNs so they can support all the practices out there who might like to have a look at those 10A reports. And if you need some information just on all the different reports available, there are various reports available through your AIR access, and the Service Australia website does detail that as well. So just moving on quickly, there's always questions about the My Health record, and so I just thought I'd pop this up, is that an individual's My Health record actually does capture all immunisations that are recorded for that patient on the register. So if it's in the register, it'll be on the patient's My Health record. So if you don't have quick access to the register and you're finding that a bit tricky, but you know that they've got a My Health record, you can have a look there. And AIR transfers that information overnight to the My Health record. So it's really helpful, obviously, for people who are travelling. Not that, as Nick mentioned, many people will be travelling over the next little while. But of course, the register doesn't hold information from 100 years ago. It's been going since sort of 1996, but and obviously in the last few years it has been an adult register, so it's not going to have everything on it. But if you want to keep historical vaccination encounters up there, you can upload them onto the My Health record via the shared health summaries function. So, you know, just be conscious that, you know, the AIR is great and it's going to get better as time progresses, but for adults there, it's not always going to have everything, particularly if they've had vaccines sort of more than 5 years ago, because the register for adults only came into being at the end of 2016. So as I said, everything should be sent to AIR, particularly from now, and then the My Health record will be up to date. So just finishing with some key messages. Please keep your software up to date. I know it's always a bit of a pain, particularly if you need to get your IT person in to do that, but it is really important. Always check your patient history if you can, making sure that the correct information is entered in the practice software. Sending all the data for all individuals to AIR, no matter what their age, and obviously the exception is Q fever, but everything else now should be recorded on AIR that you give. And sending it at the time of service. Don't delay sending your data, sort of wait until the end of the week, because the more vaccines you have, and if there's a problem with one, often it can hold up everything else. So doing it more regularly is great. And you still need to prepare and batch the claims and press the send button. So although in most practice software it is automatic, it's only automatic after someone presses send. So making sure that that's happened. Have a look if your claims have been transmitted successfully. If there is an error, if there's a demographic problem, or the postcode saved in the wrong spot in the practice software, just make sure you fix that up. And start accessing AIR via PRODA and HBOS. So I'd love to see those moving over now. And you as an individual do need to start accessing and registering for PRODA. Your organisation does need to do something as well, but every individual also needs to register themselves. So get your licence, get your Medicare card, get your passport or another form of ID and log on and do that. And have a look at those reports that are available. It's really useful. If you want to stop those phone calls coming in, or you want to stop, catch those people before they're considered overdue, have a look at your 10A or your 11B or your 11A reports. So as I was sort of saying, there's a few resources available. In my role, I put together this sort of enhancing data quality and a tips and tricks sheet. And the centre has put that up, and I know that Michelle will probably do a local version, but you can go onto the NCIRS website. It does talk about, you know, particularly someone's new to this space, or somebody new working as a practice nurse or reception staff, just some of the tips that you might find about data quality and making sure that everything's up to date. And there's some specific information there about some of the practice software, particularly Medical Director and best practice. As I said, there's lots of advice online from the Services Australia website. And of course, you've got a great team in Western New South Wales, and Michelle and Wendy have assisted in sort of providing their details so they can be contacted if you need some help, particularly around the 10A reports and the overdue reports. So that's the end. That's where you can find me. I don't mind receiving questions, but you know, happy to help where I can. But you know, data quality and data entry and ensuring good quality data is everyone's business, and hopefully you know, if we can have it done well from the beginning, then it makes everybody's jobs and your jobs easier when you're not receiving those phone calls. So I think that's the end. Yep, that's the end there. So I'm just going to stop there, and I'll happy to take any questions.
Thank you so much for that, Lauren. We're at 9:25 at the moment, yes. So we're sort of 40 minutes over time. So we might take the questions on notice if that's okay.
Yeah, sure.
I think a lot of the questions that have come in, you've covered as you've progressed through the presentation. So to anyone that has given us a question, we'll take those on notice because we realise everyone's got to get to work tomorrow and finish off their evening. But thank you so much, Lauren. That was a really excellent presentation. And we'll just try and share my screen now. So we'd just like to thank everyone for participating tonight, and of course a very big thank you to our presenters who have given us their time and expertise this evening. Thank you also to GSK for their support. The resource packs that they're supporting us in providing will be posted out shortly to all of those who put in a request form. Now, on your screen, you should be able to see the QR code for the evaluation. So if everyone can scan that, although I'm not sure if you can see that. I'll just be a moment, I apologise. Okay, there's the QR code, I apologise. So if you can scan the QR code with your smartphone, open up your camera, you should be able to scan it. It'll take you to SurveyMonkey to complete the evaluation for this evening. Otherwise, the link was also in the reminder email that was sent to you about an hour before the webinar, and it will also be sent again tomorrow. So I'll just leave that QR code there for a moment for everybody to have a chance to scan it and complete the evaluation. I really appreciate your patience tonight and sticking with us after that bit of a bumpy start that we had. And like we said at the beginning, we really congratulate everyone for their focus on keeping really high rates in Western New South Wales for our immunisation rates, particularly this year with the pandemic environment that everyone is in. So thank you all for joining us tonight. I hope the rest of your evening is wonderful, and we look forward to the New South Wales immunisation
available on the health.com.